Hello, it's Professor Jones, and this is March Madness. And this week we're talking about GI disorders. And so today I'm going to talk to you about ulcerative colitis. So yesterday, or the other day, I should say, I spoke to you about Crohn's disease. Well, ulcerative colitis is a chronic condition. It is also an autoimmune disease that develops in your intestines. And as I said the other day, it is your large intestine. So this one is confined to your large intestine. These symptoms can come and go. So ulcerative colitis is also hard to diagnose because sometimes people have like tons of symptoms and then they go away, leading them to believe that, oh, I just had a stomach bug, or, I was getting over something. So it can take a while for you to get a diagnosis for the ulcerative colitis, as is the same with Crohn's. So with the inflammation in the lower intestine, that would be considered colitis. It becomes ulcerative colitis when that inflammation ends up having sores and ulcers in your lower intestine. So you can imagine if you have a lining, the lining has a job to do, and it's going to help to absorb fluid from the stool, that the feces, I should say, that passes from your upper intestines. So if it's going to absorb fluid and other minerals that your body needs, if the lining is inflamed and has sores and ulcers, it is unable to do what it's supposed to do. So you can see why that would be a problem. These people tend to have abdominal pain, just like Crohn's, but they tend to have an urge to defecate and are unable to get that relief. So they go to the bathroom, nothing really comes out, and they just still continue to feel like they have to use the bathroom, and they are unable to. They also almost always have bloody or mucus stool, because again, the problem is in the lower intestine. So all of this stuff is happening right before the stool comes out. They often have diarrhea. They can also have a fever as well. So can Crohn's too, because if it develops into infection, or you have the whole autoimmune thing going, so your body thinks it's under attack. So all of this happens as your body is trying to, help itself. It thinks it's under attack. So you can also have a fever with this. They also are fatigued. They have a loss of appetite, and they can also have weight loss. So you see both of the symptoms kind of overlap for both diseases. There is a connection, though, between people who have ulcerative colitis and arthritis. So they also complain of joint pain, and they think that this has something to do with the genetics of getting it, the disease. And also your inflammatory markers are up. So it makes sense that you could also have problems in your joints because you'll have inflammation. These people are also at risk for malnutrition, same thing, because your intestines are not doing their job as well because they have inflammation on board. Some of the management for them would be short-term steroids. Again, you don't want to be on steroids for a long time. Biologic meds, again, are something newer, I should say, that's out there that helps the patients who, conservative management is not working well for them. They might even be put on anti-diarrheal meds to kind of help to slow down so they're not putting out as much. And with them, diet changes are really something that you want to push. So these are patients you want to see the nutrition. You want to make sure they get a referral to the nutritionist. They want to avoid certain common trigger foods, which are usually most people who have ulcerative colitis have problems with digesting. And that would be foods, dairy foods high in fiber. And that tends to go against what we think. You want to push them to have a whole lot of fiber. But with these patients, those can be trigger foods because the colon is spasming trying to help digest it. Also, whole grains, alcohol, caffeine, spicy foods, and carbonated foods are things that they should avoid as far as those being triggers. These patients, again, they're diagnosed with a colonoscopy, blood work, almost the same thing. So you're ruling out any inflammatory bowel disease when the patient comes in complaining of the abdominal pain and the weight loss and all the symptoms I stated before. So there's your 5-minute wrap up, ulcerative colitis. Hi, it's the nursing professor, and it is March Madness. And so we're going to talk about, because March also has the topic of colorectal disease awareness. So we're going to talk about some GI diseases that could happen to you or that you should be aware of for your patients that you're assessing. So what I wanted to talk about today was Crohn's disease. Crohn's disease is an autoimmune disease of the GI tract. And the difference between Crohn's and colitis, because people get them mixed up sometimes, is that Crohn's can affect any part of your GI tract, all the way from your mouth all the way down to your anus. So it can cause problems anywhere along the tract, whereas colitis is confined to the large intestine only. So Crohn's is totally an inflammatory thing. So what happens is you have pockets of your bowel, wherever it's affecting you, that are inflamed and are not working properly, which causes, most of these patients will come in complaining of abdominal pain. You can also have fever with it. You can have a chronic diarrhea or exhaustion. These patients often look tired, fatigued, and sick, like they don't look well. And simply because, wherever they're having this problem with their bowel not working right is really causing them problems with digestion and also with gas and bloating. They also have gas and bloating, nausea, and there's a lot of pain when defecation. I should say pain upon defecation. They will complain that when they go to the bathroom, they have pain. They can have blood in the stools, but with Crohn's disease, you don't typically always see blood. You will see blood in the stool almost always with colitis, ulcerative colitis. So this affects as many as 800,000 Americans. And the symptoms, of course, are going to vary depending on where it's affecting this particular patient. Some of the treatments are going to be short-term steroids. You don't want to be on steroids long-term. So they'll use it to calm down a flare. They can also have you also want to do diet modifications in them, and a lot of times they need to see a nutritionist because you want to rule out intolerances of food. But there's no specific Crohn's disease diet. It's going to go by what is affecting this particular patient. Vitamin supplements. They also have immunosuppressive drugs that they might put them on if they're having a really hard time, as well as biologic drugs. Those are the newer ones, and they target some of the enzymes or the proteins that cause inflammation. So they attack it in a different way. Some of the complications for people having Crohn's disease is that they are at a higher risk for colorectal cancer. They can develop fistulas or abscesses. And malnutrition is a big deal because it can be in the small bowel, which is where a lot of the digestion of the different minerals that your body needs is done. So you will see them often be on vitamin supplements on the other side of it once they're diagnosed, just to make sure that they're getting everything that their body needs. Some of the screenings that they'll do to diagnose this is blood work. So you're looking at CBC because you're looking to see if they're losing any kind of blood anywhere in the bowel. So you're seeing if they're anemic. They will also sometimes have B12 deficiency. So you're looking for that as well. They can do a stool test to look for signs of inflammation in the bowel. And a C-reactive protein, because that measures the amount of inflammation in your body. And a colonoscopy is what they're going to do, because then if they don't see anything in the colon, then the thought is, oh, well, it's small intestine. Or they could have some pockets in the colon as well, because again, Crohn's disease can affect the entire GI tract. This is difficult to diagnose for these patients because the symptoms are vague. They have abdominal pain. When I say vague, like they go with a lot of things. And the gas and bloating, they could just easily tell them that, oh, maybe you ate something that didn't agree with you, or you are getting over some type of GI disturbance or something. So it's often difficult to diagnose, but once they do, then the treatments are along the ones that I just listed. So there you have it, Crohn's disease. Hey, it's Professor Jones, and it's the nursing professor, and we're doing March Madness, and today's GI topic is irritable bowel syndrome. Notice out of the other two diseases, those were diseases, and this is a syndrome. This is considered a syndrome because there's no pathophysiology. It's very unclear as to what is actually going on in the body that's causing the symptoms that these people come with. Also, people who have irritable bowel syndrome, there are 3 different types. You can have IBS with constipation, you can have IBS with diarrhea, and you can also have a mixed bag. So sometimes you have constipation maybe for a couple of days followed by days of diarrhea, and so on and so forth. These patients, though, this affects 9 to 23% of the population worldwide. So that's a significant number. We're basically saying almost a quarter of the world's population has irritable bowel syndrome. So you would think that there would be more information and stuff out there, but apparently, from the research and stuff, they haven't been able to come up with pathophysiology of what's actually happening in the body during these different times of flares. These patients tend to visit the doctor more frequently. They use more diagnostic tests. They consume more medications. They miss more time at work. They are less productive, and they tend to be hospitalized more frequently. Which means that this is really something that affects people in a bad way. They also tend to have less happier lives because of what they're dealing with. And because there's such a strong psychological component to this, there are a lot of people who have this and haven't gone to get help. So they could be masking something serious that they actually have by thinking that they just have the IBS. The symptoms of IBS is abdominal pain, and more than not, it's usually in the left lower quadrant. They have straining, urgency, and bloating. One of the biggest features of IBS is that they tend to have relief, sometimes not full relief, but relief with defecation. So they have all this abdominal pain and cramping, and once they're able to go to the bathroom, then they feel better. These patients that they definitely deal with, you want to manage their diet so they can see a nutritionist. There's a thing called FODMAP, and I wanted to make sure I said these things correctly, so I wrote them down. And they are also often told to be on a low FODMAP diet. And so FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So those are all the things that they should eliminate. And if you look it up online, you can see they list a lot of the things, and they have to do with like sugars and things that are known to be a trigger to people with IBS, especially those who are having irritable bowel syndrome with diarrhea. So management with them would be increased water intake, fiber supplements, antidiarrheals if they're having the diarrhea action of it, increased fiber, probiotics, cognitive behavioral therapy, so relaxation techniques. They want them to be seeing a therapist if at all possible. Anticholinergic or antispasmodic drugs, because then they have the powerful spasms, which is what causes the pain in the left lower quadrant. So they do often give them medications for that they can take. Also meds to alter the bacterial flora in the bowel is also something that they also give to help manage this. So this is a significant syndrome that affects a quarter of the world's population. Irritable bowel syndrome. There's your 5-minute wrap up.